Hello, my name is Susan Meffert. I'm an associate professor of psychiatry at the University of California, San Francisco. I'm delighted to be here with you today. I'm going to be speaking quickly to tell you a little bit about the SMART Dapper study, which has been ongoing in Kenya. I'm an MPI in the study. The other MPI is Dr. Muthoni Maathai, who's at the University of Nairobi. And I'm going to begin now with the sharing of my slides. SMART Dapper is a mouthful to say because it's supported by two different R01s from the NIMH, and they constitute the SMART and the Dapper respectively. Just to begin briefly with a quick look at the global burden of disease from 2019, focusing on East Africa and mental disorders in that dark blue, just want to point out the massive burden of disability, YLDs, on the y-axis, and disability beginning in young adulthood. The reason why, of course, is that 75% or more of people with serious mental illness never receive any treatment at all. And that number is even higher than 75% in many regions of sub-Saharan Africa. Which disorders are we talking about? They're nothing scary, exotic, or frightening, much to inconsistent with many public conceptions of mental disorders as frank psychosis. In fact, they are everyday things like depression and anxiety that create the most burden, things that we or our friends and family members have all experienced. Just noting also, there's been this huge increase of both depression and anxiety since the onset of COVID. Lest we think that depression exists only in high-income countries, that is most certainly not true when we look at the data. If you look all the way over on the right-hand column, you can see the world put together, with women, as usual, having a slightly higher rate than men, over 5% of the general population. But if we look at the left-hand column, we can see that the Africa region, women living in Africa and men living in Africa, have some of the highest levels of depression in the world. Certainly not a problem that just exists in the US and Europe. I won't go into detail on this slide, but I wanted to mention it for this policymaker audience. There are massive economic consequences for failing to treat depression. It's extremely expensive to leave depression untreated because it results in decreased performance at work, decreased income, decreased tax base for governments. It also incurs huge physical healthcare costs because people with depression keep going back to the doctor, and the doctor keeps ordering various tests and specialist visits that don't have anything to do with treating the depression itself. They're presenting with things like headache or stomachache, and people are missing the fact that this is simply depression that needs treatment. Happily, we have a great net rate of return when we treatment. For every dollar we put into it, we get about $3 back in increased productivity and decreased healthcare costs. The background of this study: we work with Kenyan and Ugandan ministries of health and our key stakeholders to treat a major depressive disorder and post-traumatic stress disorder in a primary care adult population in Kisumu County Hospital, to be specific. This is our team. I want to highlight that we have from the very beginning included high-level policymakers, including Dr. Simon Njuguna, who's head of mental health for Kenya, and many others that I'll let you review there. Our outcome cores and deliverables include heavy focus on economic analyses and creation of a health policy menu, health policymaker menu, so that policymakers can select a package of care that matches with the finances that they have available. Briefly, this is our study. It uses what's called a SMART design, a first-line treatment randomization followed by second-line treatment randomization. And importantly, we use an implementation science model to guide our thinking from before we even launch the study all the way through the conclusion of it. This includes stakeholders and annual meetings with all of our stakeholders focused on how we can change the study within scientific parameters to achieve better sustainability and better scale up and better relevance to policymakers. This is just one model among many, but we like to use the EPIS model. This is briefly a little bit of information about how we adapt the study as we go forward to make it more relevant for policymakers. And one of our goals is to make sure that the study that we do at one county hospital in Kisumu is relevant across various counties in Kenya and also in Uganda. Our most recent IRT meeting happened just last month, and that's our implementation resource team meeting of all of our stakeholders, including lots of policymakers. And then, of course, all the way across every level, the hospital administrators, the community health workers, the providers of treatment in our study, and most crucially, the patients who receive the care, the users. So far in our study, we've screened about 3,800 people, and we've enrolled and randomized about 2,000 people. We've had extremely high retention in our study, just under 95%. And I'll be talking about that a bit more in the future. In these slides. Importantly, during COVID, we had to transition to delivering mental health care via flip phone, not smartphone, because we couldn't be sure that everyone had access to a smartphone with video capabilities, but we knew everyone had access at least to a family flip phone. So during COVID, we transitioned to making telephone treatment optional. We also allowed people to continue coming in, but we wanted them to be able to have the option to do their care and assessments over telephone in case they had COVID or were worried about getting it. We found tremendous acceptability of telephone treatment, even at baseline, and that has continued to increase across the study intervals. In terms of our baseline data, about most of the people in our study so far, about 86%, have both major depressive disorder and PTSD. And in terms of violence that would be driving the PTSD, we have a great deal of intimate partner violence that we see. Over half of our study population have had intimate partner violence in their lifetime, and about 18% over the past week. Lots of people with high levels of different types of trauma over their lifetime. And the disability score was very high. This is what we were talking about at the beginning with the YLDs. We saw in our population, we have seen so far in our population, that at baseline, when people come into the study, they're so disabled that they're missing at least 8 days of work every month due to their health condition. In terms of fidelity and adherence, that means patient attendance of their study treatments and the non-specialist adherence to study protocol. Both have been extremely high. We see that for the IPT arm, the psychotherapy arm, people are coming in, making their appointments more than 95% of this time. With fluoxetine, the medication arm, we see they're coming in and taking their medication about over 80% of the time. And the non-specialist provider adherence to protocol is also very high. We look at the treatment costs. We did this carefully, again, with our attention and our eye on policymakers, knowing that they need to make tough budget decisions when it comes to health budgets. We have analyzed so far the cost of providing IPT and fluoxetine. This is a slide showing the provider costs, and this second slide combines the provider costs with all the other costs, including the cost of the medication for the fluoxetine arm, the cost of supervision, even the cost of second-line treatment for those few that need it. And we come out with something quite low already. For fluoxetine, it's about 37 USD. That's those are in Kenyan shillings. So that comes out to about 36 USD, 37 USD. And IPT currently is a little more expensive at 93 USD. In terms of our other economic productivity data is quite exciting so far. We have seen that only about 62% of our participants were even earning a monthly income at baseline, any type of income that includes informal income, not just wage. But at month 9, when both randomized groups had already received their first line treatment, we were already up to 75%. In addition to that, not only did more people earn an income, but those people who earned an income earned a great deal more. So this is the amount, the amount of shillings that people earn per month. And we can see this huge jump already at the 3-month time point, which is the conclusion of IPT, but fluoxetine is still going on. And then going out to month 9, we see an even further jump up. So when we look at this, of course, this is really exciting for the participant and the household that they have so much more money in their pocket. It should also be of interest to the government. Essentially, if you think about the tax base that this represents, the treatment has already paid for itself at month 3. Likewise, we see that in terms of the days over the past month that people were partially or totally unable to work, there's a dramatic decline. Remember, I mentioned that at baseline, about 8 days out of the month, participants were either partly or totally unable to work due to a health condition. We see this dramatic drop down to less than 1 day per month that they were totally unable to work out at month 9. So evidence to policy takeaways, our study in terms of recruitment rate and adherence to care demonstrates a huge unmet need and demand for depression and PTSD outpatient treatment among these public sector primary care patients. In Kisumu, we have demonstrated the feasibility, acceptability, and scalability of non-specialist evidence-based clinic integrated care for depression and PTSD, including both face-to-face and mHealth treatment delivery. And we have shown with our preliminary data, high economic return on depression and PTSD outpatient mental health services, even during the severe COVID-driven economic downturn in Kisumu. So I will stop there. And put our information up, both mine and Dr. Mathai's, for any follow-up questions. Thank you so much for your time.